Today I am dictating history and physical for patient with the initials LD, 67-year-old female. Date of service was October 10th, 2014, as well as date of admission. This patient was admitted to general surgery from a different facility, and we have been asked to consult her for medical monitoring immediately post-op. The patient's chief complaint upon arrival to our hospital, she stated, "I haven't had a bowel movement since September 29th and my stomach hurts." The history of present illness states this is a 67-year-old female that presented to another ER and was immediately direct admitted to our hospital to the services of general surgery for possible bowel perforation. The patient reports that she has had a sore on her abdomen for about 6 weeks that is continually getting worse. She went to Integris Baptist on September 29th for a colonoscopy, where she had a polyp removed from her colon, but otherwise she reports a normal colonoscopy. The patient has not had a bowel movement since that colonoscopy and states that she has had worsening abdominal pain. The patient was direct admitted to our ICU here and taken for emergent surgery earlier today with exploratory laparotomy. The patient was found to have a strangulated umbilical hernia that had begun to necrose within her abdomen and outwardly to her skin. The patient had approximately a tennis ball size wound on her abdomen. She underwent CVC placement, a reduction and repair of the strangulated umbilical hernia, right and proximal colon resections due to ischemic bowel, a cholecystectomy, and a drainage of an abdominal abscess. The patient's medical history includes diabetes, hypertension, chronic renal disease, stage 4, and liver insufficiency, though she cannot tell me how severe her liver disease is. The patient's surgical history is only limited to the colonoscopy that she had a couple weeks ago. She denies any other surgical history. The patient states she does not take any medications at home. She states that she controls her diabetes with diet, and her blood pressure medicine makes her feel weird, so she does not take it. She appears to be non-compliant with her health care. The patient is not allergic to any food or allergies. She lives at home alone, is never married, and has no children. Her next of kin is her brother. Her mother is currently alive. She's a 90-year-old female and has diabetes and hypertension, and her father died in 1980 from alcoholic cirrhosis. The patient does not take immunizations normally and has not had her yearly influenza and pneumonia vaccine. Upon review of systems, the patient denies any visual changes or blurred vision. She has no ringing in her ears or hearing loss. She has not had any sinus issues or nasal drainage. She does not have a sore throat or difficulty swallowing. She is not confused. She denies dizziness. She does not have memory loss or changes in her mood or behavior. She does report increasing fatigue over the last 4 to 6 weeks. She denies any cough or shortness of breath. She denies any blackouts, palpitations, edema, or DVT in her history. She does report a history of high blood pressure, but states that she does not take any medications due to the fact that they make her feel bad. The patient does report abdominal pain and decreased appetite since 9/29. She denies the fact that she's had nausea or vomiting associated with her abdominal pain. She does report a history of liver failure, though she cannot tell me what kind or how long. She denies any pain with urination or blood in urine. She denies frequency and urgency, but does have chronic renal insufficiency. The patient reports that she has had decreased strength over approximately the last 4 to 6 weeks, but denies any history of arthritis, swollen joints, or neck pain. Upon physical exam, the patient's vitals are stable immediately post-op. Her blood pressure is 135/58. Her pulse is 94. Respiratory rate is 20. O2 sat is 100% on 2 liters, and the patient is afebrile. General appearance, the lady is a obese Native American Indian woman. She is laying supine in the bed with facial grimacing notice and is immediately postoperative. Speech is appropriate, and the patient is alert to person, place, and time and purpose, although she is slightly drowsy. Her head appears normal with no noted malformations or trauma. Her facial expressions are symmetrical. The patient does have perla. Her pupils are 2 millimeters bilaterally and reactive. Her eyes are free of drainage or redness. She has no apparent signs or symptoms of hearing difficulty, and her ears appear normal bilaterally. No nasal redness or drainage is noted. Her neck is supple without swelling or tender nodes. No JVD is noted. Respiratory, she is slightly short of breath while having conversation with me, though she states that this is normal for her. She is 100% on 2 liters per minute nasal cannula. Cardiac status, she has regular rate and rhythm at sinus rhythm 94. S1 and S2 are present with no gallops, murmurs, or rubs. Capillary refill is less than 2 seconds in both extremities. Her abdomen is soft, though it is tender to palpation due to the midline incision. Bowel sounds are absent at this time. There are no masses felt with palpation. The patient does have a new Jackson-Pratt drain to the right lower quadrant that is compressed with sanguineous drainage. She denies any pain or bleeding with urination, though she currently has a Foley catheter. The patient does have good muscle tone. All her cranial nerves are intact. Her sensation to light touch is intact bilaterally, and her deep tendon reflexes are intact bilaterally. Her grips are weak, though she reports weakness over the last 4 to 6 weeks. Her laboratory findings, her white blood cell count is slightly elevated at 12.4. Her hemoglobin and hematocrit are stable at 12.5 and 34.8. Procalcitonin was elevated at 1.96, indicating underlying sepsis. Her potassium is 3.3. Her BUN is 109 and creatinine is 2.04 due to renal insufficiency disease, and the patient states this is pretty close to her baseline. Her glucose level is 223. A postoperative chest x-ray is normal and shows placement of a new right-sided subclavian central venous catheter during her operation. The preoperative CT of the abdomen indicates that she had free air in her abdomen, thus warranting her admission to the intensive care unit. The patient is going to be diagnosed with sepsis, intra-abdominal abscess, and a strangulated umbilical hernia, both of which were repaired and evacuated in the OR, chronic renal disease, and hepatic insufficiency disease. The plan for the day is that I am going to take hourly vital signs, hourly intake and outputs for 24 hours. The patient is NPO per general surgery. She's going to ambulate every 8 hours. She will have maintenance fluids of D5 normal at 125 per hour. She's going to be on Protonix 40 milligrams IV daily for GI prophylaxis and Lovenox 30 milligrams sub-Q daily for DVT prophylaxis. I will start the Lovenox in the morning due to post-op status. The patient is on a PCA of morphine for pain control, which does appear to be controlling her pain at this time. Started her on broad coverage for antibiotics. She's on cefepime 2 grams IV every 12 hours and Flagyl 500 milligrams IV every 8 hours. She has a Foley to dependent gravity drainage, and I'm going to order lab for the morning, which includes a CBC with differential, MET-PC, procalcitonin, liver function tests, and a CRP. Also order a 2-view chest x-ray, and then I will follow the cultures collected from the abdomen during the surgery. Thank you.